Continuing Care, Chapter 48. The overall therapeutic goals of treatment are to arrest the disease and provide oral health, function, and comfort for the patient. After active treatment, when evaluation shows that the soft tissue is now at optimum health and the dentition has been restored in function, the patient enters a new phase of treatment for continuing care. We need to continue caring for the teeth to keep them in that healthy state. So our objectives for this chapter include describe the goals of a continuing care program in dental hygiene practice, determine appointment intervals based on an individual patient's risk factors, compliance, and oral health history, name and discuss the contributing factors in recurrence of periodontal disease, list steps in a continuing care appointment, including assessment, care plan, and therapy. And the last one is outline methods for continuing care systems in the dental office or clinic. So up to this point, we have completed our ad pie, okay? We've done our evaluation. Now we need to go and set up some goals of the continuing care program. How are we going to now maintain what we've done and what we've accomplished with our patient? So the goals of the continuing care program is to, one, continue the healthy state attained during active therapy. Active therapy is that therapy that we've provided during the care of the patient. That's considered active therapy. So if you're doing scaling and root planing from the first appointment till you finish the last appointment and done the reevaluation, now they're done with active therapy. Prevent reoccurrence of infection. The patient needs to understand that oral diseases recur. They can keep coming back, okay? Periodontal disease works in phases, and we have inactive phases and active phases. And so we want to let the patient know that diseases can reoccur, but control is possible through combined personal and professional effort. So they need to do their job, we need to do ours. Prevent initiation of new disease. So what are our primary preventions, right? Primary prevention would include fluoride, would include oral hygiene instructions, and this is when there's no disease, we're preventing anything from happening, anything new from developing, okay? Monitor educational and behavioral changes. So we need to consistently be monitoring what the patient understands and any changes in their behaviors, in their oral hygiene behaviors. And remember, those can be influenced by many different factors, okay? I think I've said in the past, I've had patients that just lost a spouse, okay? Taking care of themselves is really difficult during that time. So there might be a little bit of a behavior change. Those home interventions may not be quite up to par. So what we want to do is encourage the patient to just get back on track. We can't go backwards and redo it, but we can move forward, right? And then educating them on the importance of those changes, okay? Then we want to monitor risk and clinical signs of health and disease, including periodontal infection. Periodontal disease is an infection. Oral mucosal lesions, dental caries from mineralization to non-cavitated, from non-cavitated to cavitated lesions. 6, provide specialized instruction for new implants, prosthesis, orthodontic appliance, and various restorations. So how are they going to clean that new implant? How are they going to clean that new denture or that new partial? How are they going to clean around their braces? And we talked a little bit about that already, right? We talked about the phones brushing method, right? And various restorations. So how do they floss under a bridge? Okay. 7, offer motivational encouragement for oral self-care. The success of the program depends on compliance by the patient with the daily oral self-care and regular professional maintenance. They are considered the co-therapist. The patient is the co-therapist. And we need to remember that we can't do it by ourselves and they can't do it by themselves, okay? It is a team effort to restore and maintain health. Number 1, periodontal maintenance. Patients who comply with regular periodontal maintenance intervals have less attachment and tooth loss. It is proven that a 3-month recall works, okay? Period. It's very important. It's an important part of the care plan. Evidence suggests patients with a history of periodontal disease need to be seen 4 times a year. I want you guys all to write that down. Need to be seen 4 times a year to decrease the risk of progression of the disease. Therapeutic goals of periodontal maintenance include the following: prevention, to prevent the recurrence of disease and maintain state of periodontal health attained through and during periodontal therapy. Such therapy may have been non-surgical or surgical. Okay, so any type of periodontal treatment indicates that the patient needs to come in every 3 months or 4 times a year, right? 12 months in a year. If they're coming in every 3 months, they should be coming in 4 times a year. Now, this is coded a little bit differently. It's a different kind of cleaning, okay? We have a prophy and then we have perio maintenance, and that's the maintenance of periodontal disease, okay? Now, we also want to prevent or reduce the incident of tooth or implant loss with careful monitoring. So that includes probing, x-rays, cleaning. All that is included to help prevent loss of implants and teeth. And yes, people do lose implants. They can get peri-implantitis. So we want to make sure that they understand that and that we're teaching them how to clean those areas. And we will have an implant unit coming up in another course, okay? And then increase timely identification of the need for treatment of other conditions or disease manifested in the oral cavity, such as HIV/AIDS, okay? There is also, what am I thinking? Diabetes, right? We want to check that. Leukemia, we want to check that, right? All right. Let's move on. Also, please do review box 48.2. That'll be really helpful for you. All right, here is box 48.2 or -2, and I am going to read this to you in case you're just listening on the road or anything like that. So, purposes and outcomes of periodontal maintenance. This is our 4 times a year, every 3 months maintenance appointment. We want to resolve any inflammation that's starting. We want to eliminate any bleeding on probing. So when you're taking those periodontal measurements, you want to eliminate bleeding during that. We want to restore tissue to normal contour and texture, create an environment for healing, arrest disease progression or stop disease progression, provide patient comfort, encourage patient oral self-care, and create environment that deters recurrence of infection. And lastly, motivate patient to participate in continuing care. Again, I can't say it enough. They are the co-therapist. We can't do it without them. They can't do it without us. That makes us co-therapists. The dental hygiene process of care is described in this chapter. Now, remember, we start with assessment, right? So what are we assessing? We want to assess the patient's medical history, right? And we're doing this every 3 or 4 months, but usually every 3 months with perio maintenance. So we want to review the medical history. Supplementary questions are asked to determine the present state of their health with an emphasis on changes since the previous appointment. Remember, we update the medical history at every visit, but the patient completes the medical history themselves once a year. Okay, so you're updating it at every visit. The patient completes it every year. We also want to know if there's any recent illnesses, hospitalizations, any changes in medications or medication doses, and anything else that might be pertinent to the assessment, okay, what we might be finding in the patient's mouth. And this isn't on the medical history here at Herzing, but I always do ask the last time they had a physical exam with a primary care provider. And why do you think I ask that? I ask that because do we truly know the patient's state of health if they aren't going to see their physician regularly? Okay, so when you're in clinic and I'm your instructor, I always like you to ask the patient, when was your last physical? Okay, and they say, oh, I saw my cardiologist. Nope, when was the last time you actually were evaluated by your primary care physician? All right, and some people it's been 5, 10, 15 years. And so it's really important that we ask them that question so we truly know what their health status is. Next is our vital signs. Remember, for our vital signs, we talked about this in chapter 11. We're going to be recording the patient's blood pressure, their pulse, their respirations, and then if they are sick, we may take their temperature also. Okay, so always remember to review the findings with the patient and record which arm you took the blood pressure on. Okay. Another thing you want to know is that if the patient has had a mastectomy, then we want to take it on the opposite side, the blood pressure on the opposite side. So if they had a double mastectomy, then we would want to take it on their leg. Okay? Our extraoral and intraoral examination, we want to do a thorough intraoral and extraoral examination, and you can review that in chapter 12. Now this is our assessment every 3 months, okay? Radiographs, the frequency of radiographs is determined on the patient's needs. Now generally if they have periodontal disease, we're going to be taking a full mouth series every 3 years rather than every 5 years on a healthy patient. The periodontal exam, we are going to observe and record the color, the size, the shape, and any mucogingival changes. That's when we took our measurement from the gingival margin to that MGJ, the mucogingival junction, and then we subtracted the pocket depth. Okay, and if there's any changes in that, they need to be monitored very closely, and they may need a graft in that area to either thicken the tissue or to create a longer junctional epithelium, a longer attachment. So you want to make sure that you record all of that. You also want to record the pocket depths, the bleeding on probing, any exudate or suppuration, attachment levels, furcations, gingival recession, and then you're going to compare it with the previous exam. So the one 3 months ago. Okay? Then we want to check the occlusion and any fremitus. That's when the patient's biting together and you can kind of feel vibrations in their tooth, meaning there might be just slight mobility there. And then we want to check mobility. Next thing we want to assess is the calculus and the biofilm. Where are they being found and how can we prevent that? Because now we need to look at all our interventions again. Examination of the teeth, integrity of the restorations. We want to make sure that all those margins are nice and healthy and there's no decay around there. We want to check for any demineralization, any early caries, any cavitated lesions. Then we want to go and look at the oral cleanliness again. And we want to assess if their home care is working for them. Do they have all the tools and all the knowledge that they need to provide good home care? Continuing care plan. A care plan is outlined on the basis of new findings of the new dental hygiene diagnosis. And we're going to do this by evaluating the condition of all the patient's assessment findings. Okay? Oral hygiene instruction and motivation. During continuing care, the patient is considered a co-therapist. Again, we can't do it without them, so they are co-therapists. To keep etiologic factors under control, compliance with daily oral self-care is a major feature in the total program. Periodontal scaling and debridement. The periodontal examination findings may indicate need for subgingival scaling and root planing. So you want to plan appropriate control, such as local pain control, such as local anesthetic. We may also want to use nitrous oxide if the patient is a little anxious, right? We need to look at how many appointments it's going to be, the number of appointments that's going to be necessary for the patient to complete the plan, complete the program, okay? And then are we going to need to deliver any local antimicrobials, such as Arrestin, to help with those pockets? Now, generally, we don't recommend Arrestin until the follow-up. The Arrestin company always likes to say, place it at the scaling and root planing, but the more current thought is that you want to see how the patient can respond on their own with just good home care, because they're finding Arrestin to just be a bandage. The patient still needs to do what they need to do. So let's see what the response is first, and then we place it at the 6-week re-eval. We clean it out again and place it in areas that maybe didn't heal as well. So for areas of bleeding and probing, we may want to use endoscopic examination, and that's like a microscope that goes down into the pocket so you can see if there's still calculus in there. Another part of our continuing care plan needs to be dental caries control. So we need to address any risk factors that may be new and implement or monitor any previously introduced demineralization protocol, or remineralization protocol, I should say. And so that would be the use of fluoride, also any calcium phosphate products that might be out there. And we will talk about that a little bit more in contemporary issues on all the different remineralization products. But for right now, we're focusing primarily on fluoride. So any supplementary care procedures such as tobacco cessation, any hypersensitivity, special care for any prosthetics in the mouth, and then retreatment or referral is also included here. So I just want to apologize for all the misspellings. I'm finding a lot of them that are missing on these. I'm not sure what happened to them. Hopefully they were correct on yours. Okay, so let's go on to appointment interval frequency. So it's going to be determined by compliance, local factors such as calculus, and then restorative compliance. How are they taking care of their implants and their prosthetics? So special appointment requirements every 2 to 3 months are required for many patients, and a few are listed here. Patients with periodontitis, cognitive disabilities or physical disabilities, patients that have diabetes should be seen every 3 months, especially if it's uncontrolled diabetes, until they get it controlled. Cardiovascular disease and other conditions, those who have been recently hospitalized may find oral self-care tiring and may require some modification to self-care regimens at home and appointments. Maybe we need to shorten their appointments, okay, to alleviate some of the stress. Patient undergoing extensive dental care, when extensive restorative, prosthetic, or other treatment is in progress, frequent tissue maintenance during long-term therapy is really important. If your patient has rampant dental caries, this is going to be our extreme dental caries patient, then we need to look at possibly increasing their recall. Also, we need to look at placing sealants and any remineralization protocol that. Okay, sorry, the last slide skipped a little, but we were talking about rampant caries, making sure that your patient, that extreme caries risk patient, is coming in more frequently to help control it. Another thing we can do to help control it is do sealants, and we want to continually maintain those sealants, making sure that if there's any chips or if it's gone, that we replace it. Orthodontic therapy, we want to make sure that the appliances are being cleaned and free of biofilm. Also, frequent fluoride applications is really important for those patients with orthodontia because it is so hard to get all of those areas. Okay, now let's move on to this slide. When we talk about the methods for continuing care, when we talk about the methods for continuing care systems, there's a couple of methods. And probably the most common one now is to pre-book or pre-schedule. And that really helps that patient, they're already committed to the appointment. So sometimes my patients would say, well, I don't know what I'm doing tomorrow. How do I know what I'm doing in 3 months? And I say, well, if you schedule, then you know what you're doing in 3 months, right? So they can work around it. And it's much easier to get them to optimum health if they're scheduling before they leave the office. Then there is a more expensive, a little more antiquated way of doing it, and that is sending out reminder cards. And some people prefer this, okay? There's a couple ways of doing this also. One is have the patient address it to theirself, and it really gets their attention in the mail when they see their own handwriting. And they say, oh, yes, okay, I remember setting that up now. Okay? You can also do it via a digital calendar and other electronic media. So there's all sorts of ways that they can do a more updated version of the reminder card. Then we have a monthly reminder method. And if a patient is not pre-scheduled, a monthly list of patients is printed for you, and then you go through and you call them, you text them, whatever way your office uses to identify patients that are not scheduled but are due. Okay, so this is pretty much all done via computer system. I remember doing this before the computer systems, and we had like a recipe card box, and we had January, February, March, April, May, June, July, And so the patient would fill out address a card to themselves, and we would put it in that month for them to, or the month ahead if it was just a reminder for them to call. Okay. So going back up to the pre-book method, a reminder card is sent to the patient like a week or two in advance. It also could be on the digital calendar where it just pops up on their phone. Hey, you have a dental appointment in 2 weeks. Okay. Or email, text, postcard, anything like that. So we have the pre-book method, and then we have the monthly reminder method. Okay. Where at each month the office. Okay. Documentation, history is updated with medical dental information. Remember, we need to update this at each appointment. That's always going to be a question on your exams here. How frequently they update it at every appointment. Doesn't mean they fill it out at every appointment. It means that they update it at every appointment. Also, you want to document any complaints or any questions that the patient has, any findings during your routine examination and assessment, especially if there's been any changes from the previous appointment. Again, always review these SOAP notes. They're a great guide for when you get into clinic, okay? So there is a narrative format, and we practice a little less narrative. Most offices do, because it gets a lot to be reading through everything. But no, in school, we're going to have a lot longer notes, okay? And that's just for us to assess your understanding. All right, wrapping it up, here are factors to teach the patient. The purposes of follow-up and continuing care or maintenance appointments. The relationship of personal oral care habits to the maintenance. And the importance of keeping all maintenance appointments. How important it is for them to stay on that 3-month recare visit. We know that recolonization happens after 42 days. And so, if they can keep it clean and not have that recolonization, we'll be doing good, right? So that gives them half the time. That's the first, 6 weeks. Then after that, what do they do next? Okay? All right. Thank you guys all so much. If you have any questions, please let me know.